Hi, my name is Greg Kitchka. I'm a cardiothoracic imager in Seattle, Washington. I work at the Veterans Affairs Hospital and University of Washington. I've been the section chief of cardiothoracic imaging at University of Washington, and I am currently the deputy chief of diagnostic imaging at the VA. I've been the president of the North American Society of Cardiovascular Imaging, and since the time I've been practicing, when I first started, linear tomosynthesis was the only type of tomosynthesis that was available in the clinical space. But shortly after I started, digital tomosynthesis became available. The film plates were replaced with digital detectors, and for the first time we were able to do tomosynthesis of the chest and musculoskeletal areas. Our institution was an early adopter, and I spent a lot of time talking with service lines about how this new technology could meet their imaging needs. I also did research on digital tomosynthesis. I designed software to test its utility in a variety of clinical scenarios. Digital tomosynthesis was exciting, but as a modality didn't change very much in the coming years. However, this past spring, Nanox contacted me. They wanted to tell me about a new instrument that they had commercialized called the ARC. It is a digital tomosynthesis system with multiple X-ray sources. I'd never seen anything like it before, and after they showed me what it could do and what it was capable of, the images it produced, they asked me if I'd be interested in creating a lecture for imagers and clinicians to better understand it. And I said yes. I've always thought tomosynthesis is very underutilized, which is a shame because patients have a lot to gain from its appropriate use. A lecture would help people become familiar with the modality, understand how to interpret it, and think about how it best fits in for how they care for their patients. So, this is my lecture on high-resolution digital tomosynthesis using cold cathode technology. Before we get started, I would like to thank Nanox for helping me put this lecture together. They gave me images that were taken by the Nanox.ARC, clinical histories that went along with those cases. They also gave me access to their technical team so I could learn more about the unique aspects of the instrument and understand how it works. It's also important to note that the images that I am going to show from the ARC, they were acquired under the Ethical Committee permit to conduct a clinical study in Israel. I will show some images that are not from the ARC, and they'll be labeled. So let's get started. Again, my name is Greg Kitchka. I'm a cardiothoracic imager from University of Washington and the Veterans Health Administration Hospital in Seattle. And I'll be talking about cold cathode digital tomosynthesis, the evolution of high-resolution, low-dose imaging. But let's talk about some clinical cases because it really depends on how those images actually look. I'm going to show you a variety of cases, almost all of which were taken with the Nanox.ARC and a few which were not, just to illustrate what are some of the applications for tomosynthesis. This is the case that I'd like to start with because it does a good job of illustrating how the structural noise we see in radiographs can so easily obscure an important finding. This is an open mouth radiograph of the cervical spine in a patient with trauma. And when I look at C1 and C2, I don't see any clear abnormality. I see a lucency going across the dens, but it looks like it's probably caused by soft tissue. I would have called this normal, but let's look at what the tomosynthesis shows. Okay, so we have the radiograph here on the left. Here is a tomosynthesis series performed in the same plane. And right away you can see that the resolution of the, I should say the removal of structural noise enables you to more clearly see what is happening at specific planes. And as you choose a plane that goes through the mid-vertebral body, you can see there's a fracture at the base of the dens. Let me show you this on a CT exam, and you can see here's that fracture going through the base of the dens. There's no fracture superior to that, and that lucency that we did see doesn't really correspond to any pathology. It was probably caused by soft tissue. This advantage that you get with tomosynthesis is not unique to this specific study. Let me show you another case. This is another patient where tomosynthesis really shows how removal of structural noise can help you see fractures that are otherwise obscured on conventional radiography. This is a patient who fell onto their hands. They have a fracture. We're imaging them here after they've received a cast. Cast materials, you all know, can obscure a fracture. But in tomosynthesis, the structural noise that cast causes are essentially removed. So yes, you can see some fracture lines here on these two radiographic projections, but what you have trouble appreciating is on this tomosynthesis image, the cast material that is out of plane is essentially gone. It is not affecting lesion conspicuity, and you can see now that there is a fracture line that extends up to the joint space, which is important for classification and staging of this fracture. You can scroll through this volume and really see where the fracture lines are, whereas in an AP radiograph you're limited to fracture lines that are just well seen in that projection. Okay, here's a close-up of that same patient, and again you see fracture lines, but what you don't appreciate as clearly or as confidently is that extension of the fracture line up to the joint space. Really only possible on tomo because removal of structural noise. And some of these fracture lines can be a challenge to see on CT because remember, CT resolution is 0.6 to 0.4 at best in plane resolution, where with tomosynthesis you're looking at 0.1 to 0.2 millimeter in plane resolution. This is another case of a patient who had a fracture, and the fracture was delineated by some software here, and you can see it at the base of the metatarsal. And this would be compatible with a Lisfranc fracture. What you don't see, and tomosynthesis will show you, is that multiple fractures are in fact present. So if you look at the tomosynthesis stack, again, here's this cast material, and you move through it, you can see that you have fractures at both the base of the first metatarsal as well as at the base of the second metatarsal. And if I look up close, you can see that the fracture that we're seeing here on the sagittal CT is indeed visible very plainly here on the tomosynthesis image. And I believe if I go back, even this small fracture at the base of the first metatarsal is seen here on the tomosynthesis image. Here's that fracture of the second that we again see with better clarity here. These are not clearly seen on the radiograph, so there is this advantage of having high in-plane resolution, but also being able to reject out-of-plane noise. It isn't just fractures that this is good for. There are other applications like, for example, the detection of erosions in a wrist or a hand for the diagnosis of erosive arthritis. We all know those hand surveys that we get looking for erosive arthritis. It can be very important to determine whether a person has osteoarthritis or something like rheumatoid arthritis. Most people get radiographs. because they are less expensive, they don't consume as many resources, but they are not as effective at seeing those erosions. And here's an example of that from the literature. You can see you have a standard radiograph here. In retrospect, you can see this erosion. I'm not so sure I would have identified this erosion, but when you come over to a digital tomosynthesis image, these erosions are clear. There's no confusion about them. And in one particular study, the one I'm showing you, where they looked at 30 patients with these erosions, if you use CT as a gold standard, and in their case they did, detecting 232 erosions, tomosynthesis found 199 of those, whereas standard radiography only found 140. And this is a measurable difference in accuracy of those two modalities, 71% with radiography and 83% for tomosynthesis. A similar study was also done comparing tomosynthesis to MRI, and it found the performance was similar to MRI. One of the more striking findings that I found from this study was that the agreement, the inter-observer agreement for tomosynthesis was similar to that of MRI. Radiography was had very poor inter-observer agreement. Okay, let's look at this example here. Again, another fracture of the ankle. And again, you can see there's some cast material here. You can clearly see that there's a fracture of the fibula. But what's amazing to see is that there is, on the tomosynthesis image, a large fracture through the medial malleolus, which is just not seen at all on the radiograph. Here it is on CT. In some ways, I feel like it is more conspicuous on the tomo, and these were all done within a very close time frame of each other. But again, it's that ability to detect all the fractures, characterize where all the fracture lines go, and this changes how a patient should be treated, whether or not they should have surgery. And tomosynthesis really clarifies a lot of these questions compared to radiography. Okay, before we finish up, I want to show two more cases of how the overlapping objects can really obscure fracture details or abnormalities, or just how tomosynthesis can remove structural noise. So this example here is a patient with a fracture of the distal femur. All right, and the fracture line is clearly seen on both radiography and tomosynthesis. But what I want you to look at is how all the structural noise that you get from the patella on the radiograph is absent on the tomosynthesis. It is not that far in front of the fracture lines or of the distal femur, but because of all the projections that you have and the way that that anatomy gets blurred and removed, there's no contribution to this final image, and it doesn't obscure any of the radiographic findings. All right. Here's another case. This is a patient who presented with back pain, and you can see we have I zoomed up a section of a thoracic spine, a radiograph here, and I mean, I have to tell you, I would call no abnormality on this radiograph whatsoever. I'm showing you a coronal CT image here. Clearly there is an abnormality. There's a compression fracture of one of the vertebral bodies. You can't see that on the radiograph. But on tomo, you can see it as clearly as you can on the CT. Now, I recognize that some people who have limited experience with tomo may have intermediate confidence in calling this, but this is abnormal for a vertebral body. You can see that there's a small fracture line here, a fracture line here, so we've got 3 levels. If we look at the sagittal view, you actually can appreciate that. You can appreciate the 3 levels where a compression fracture occurred. And this really is an example of, the power of tomosynthesis. And it also illustrates how having familiarity with looking at the images, there's a misconception that just because you read CT and you read radiography, you should be able to read tomosynthesis. Yes, those skills help you, but it's a totally different modality, which speaks to its strength in showing us things that those other two modalities don't, and also underscores why there should be a focus on education and training in this modality, because it's worth it. There really is a lot to offer. So those are some great cases because they really show how digital tomosynthesis provides added diagnostic value in certain clinical situations. Musculoskeletal imaging, thoracic imaging, even abdominal imaging all have particular use cases that may be best served by digital tomosynthesis compared to CT or radiography. And the Nano-X system is unique in that it does not have as large of a footprint, doesn't require as much power, and also some of the acquisition strategies utilize that matrix pattern that we discussed, which really blurs out your structural noise in a way that makes the images cleaner. I hope that going through cases like this helps people become more familiar with the modality, because I have always felt as though that's one of the major barriers to this being adopted in the clinical setting. I hope you enjoy this, and thank you very much for your time.